So I am the concluding speaker for this session. I'm Chad Gonzales. I'm a gastroenterologist here in town at McKay Hospital. I work with the Ogden Clinic, and I'd like to thank Dr. Webb, the president of the society, for inviting me today to speak. And I understand that I am literally all that's standing between you and a nice weekend. And so I hope this experience is good. We'll try to make it quick. This is, I think, the third or fourth time I spoke for the Ogden Surgical Society, Medical Society. And the last time I was here, I believe I was speaking about fecal transplant. And it made for an interesting time, and I'll never forget. And we had a great time together. We looked at some interesting pictures, and I think everybody liked it. I don't think it'll be quite as interesting as that. I can't speak at this meeting without speaking about fecal transplant, so we'll talk about that, touch on that just a little bit, and about the microbiome. So I do have some disclosures, but none are really relevant to this lecture. And I'll move on. So I want to talk about appropriate use of diagnostic tests. Briefly, I wanted to touch on choosing wisely the ABIM Foundation GI recommendations, which have been adopted by our society. I wanted to touch basis and talk about some of the controversies and difficulties still in 2019 with C. difficile testing, and talk about fecal microbiome transplant. Maybe talk about something that you haven't seen as much of, but we will see more and more of, is fecal microbiome testing. What do we know about that? I want to talk about colorectal cancer screening, particularly fecal occult blood, FIT, and stool DNA tests, hydrogen breath testing, and then end with fatty liver workup and NASH, and what do you do for those patients. So this figure 2 really, I think, hits home of the problems that we are all familiar with in U.S. healthcare, is that it is expensive. That at the year 2020, in just really a year, that U.S. national healthcare expenditure will be around 18 to 19% of U.S. gross domestic product. So healthcare expenditure is increasing. It's expensive. The U.S. population is aging. The number of patients that are insured, subsidized, and underinsured is increasing. And there's unnecessary spending from over-testing, over-treating, failures of care delivery, coordination, fraud, and abuse. So in 2012, an article was published in the Annals of Internal Medicine that really talked about high-value, cost-conscious care, and recommended to not perform a test if the results will not change management. And I think it's important to remember that. And also thinking about pretest probability. If your pretest probability is low, the likelihood of a false positive test is greater than the likelihood of a true positive test. I think it's important as we think about testing that we remember those principles. And that the true cost of the test isn't just the test, but it's also the downstream costs. Let me give you an example of this. When I came into practice in 2005, in inflammatory bowel disease testing, there was a blood test called, I think many of you are familiar with, Saccharomyces and ANCA, all right, IBD-specific test. And this test was being run quite a bit in our community as a diagnostic test for inflammatory bowel disease, but maybe not knowing or appreciating that there was a high false positivity rate in just the general population. And that as a diagnostic test, it is not recommended. And it has very little clinical utility even today, and it's not run very often anymore. And so those downstream costs of that test were, well, you get a positive test, you end up in a colonoscopy, a CT scan, all of a sudden you have all this expense, and what did they find? Nothing, because the test was a false positive. So in this article in 2012, in the Annals of Internal Medicine, they came up with 37 clinical tests that do not reflect high-value medicine. And those are left up to debate. That was a consensus statement. And so choosing wisely developed, in the last decade, in the last 6 to 7 years, as an initiative in the the association, the Board of Internal Medicine, American Board of Internal Medicine Foundation, as a mission to promote conversation between patients, clinicians, and helping them choose care that is supported by evidence, that's not duplicative, free from harm, and truly necessary. Recommendations are guidelines and should not be used to establish coverage decisions or exclusions. And there is some controversy around the whole choosing wise concept, but in our society, I'll kind of fast forward through this a little bit. This just was a survey that Choosing Wisely put out that basically highlights a lot of the concerns that doctors have and why we order some of the tests we do. But the American Gastroenterology Association got behind Choosing Wisely and came up with 5 recommendations for testing that patients should question their doctors about. And I just want to touch on them just briefly. And I think that a lot of our primary care doctors are doing a really good job with this, actually. I have a lot of patients come to me that are on the lowest effective dose of PPI and H2 therapy, H2 blocker therapy for treatment of GERD. And that's important. So the lowest effective dose to treat GERD is recommended. And also just making sure that they're on antacids for the right reason, all right? If a patient doesn't remember why it was started, it's time to stop it. And I'll just tell a patient, go off of it. I want you to go off of it for 2 weeks. It may be less than that. It may be for the rest of your life. But we need to know, is this acid reflux medicine controlling acid reflux or heartburn? And then the lowest effective dose. And for me, it's 20 milligrams of omeprazole or pantoprazole. It's the lowest dose. And some of our patients can achieve that and some can. The second Choosing Wisely recommendation was do not repeat a colorectal cancer screening test by any method. That's important, by any method. In average risk patients for 10 years after a high-quality colonoscopy that was negative. All right, so it's important. A lot of our patients, well, some of them come back and they're still getting fits and they're still getting other things done. And if they had a high-quality colonoscopy screening, you really don't need to do any of that. The third was do not repeat a surveillance colonoscopy for at least 5 years in average risk patients with small polyps on their colonoscopy study. All right, and this is preventing the patient that comes back and says, you know, I get my colonoscopy every year. The doctor just said I needed it. And if you hear that, you know, you really sort of say, well, no, that's not the way we really do it. You know, it depends, right? I think if a patient was, obviously if they have Lynch syndrome or if they have had multiple polyps, high-risk polyps, a yearly recommendation might be important. It might be recommended, but inappropriate for the average risk patient. Number 4 is with regard to Barrett's esophagus. How do you do follow-up endoscopy with Barrett's? First, I think it's important to realize that the risk of Barrett's and esophageal adenocarcinoma is very, very low. I tell patients that that risk is about 0.5% per year. And if you have short segment Barrett's, it's more like, well, it's even less than that. I tell them it's between 0.1 and 0.4% per year. It's very, very small. And so if you find, if us as an endoscopist, we find Barrett's esophagus, we take a biopsy, we see it, we ask them to come back at 1 year to confirm if they have an endoscopy with Barrett's at the first year and there's no dysplasia, they really don't need a repeat endoscopy for 3 to 5 years. All right, so if you see that come across your desk and it's a yearly endoscopy for Barrett's, you sort of have to question, well, gosh, have you had dysplasia? You know, what's going on? And then lastly, gets to the idea of those most difficult patients, I think that our primary care and general practitioners see a lot, and our ER see a lot, is the functional abdominal pain patient who's had a pretty good extensive workup. They've had a CT scan, they maybe have had their gallbladder out, they have a functional pain syndrome, and really shouldn't have repeat CT scans done routinely unless there is a real good reason that they've had new change in symptoms, weight loss, vomiting, anemia, those kind of things. So, changing gears, I want to talk about C. difficile testing. and some of the problems I've seen crop up kind of lately. With a clinical case, a 52-year-old female with remote history of C. diff presents to the ER with 5-day history of diarrhea 4 to 5 times a day, low-grade fever, tachycardic, dehydrated, and she had a positive PCR in her primary care's office. But she is not getting better because she's on antibiotic therapy with metronidazole, right? So are there additional tests? Is there a role for scoping, doing a colonoscopy, and treatment considerations? So who do we test with C. difficile infection? The IDSA is our infectious disease society in America, and the ESC-MID is the European counterpart. They recommend really testing for C. diff if greater than or equal to 3 unformed stools in 24 hours, unexplained, and new onset. So patients that come in that have, I get kind of hard stools and I'm going once or twice a day, I wouldn't do it. Really hold to that, to this kind of testing, because you're raising your pretest probability if you have diarrhea versus not. Only liquid or unformed stools, what the European counterpart recommends. What test to run? They both recommend a multi-step algorithm. This algorithm is used in our hospital labs. And when should you repeat? Should you do a repeat test? My patients ask this all the time. I usually tell them no. If you're clinically improved, let's not repeat, because spores are present in stool for several weeks, and a positive test may indicate only carrier state and not the presence of active C. diff. And so the IDSA recommends nothing before 7 days, and our European, the counterpart, recommends nothing up to 6 weeks. So what tests are available? An antigen toxin test. This usually involves GDH. Toxigenic PCR, I think people are familiar with that. That comes, if you order at Ogden Regional, it's a toxigenic PCR. If you can order a gastrointestinal film array PCR panel at McKay. At Ogden Clinic, they have like a GI-22 panel, which is a PCR test. I think the important thing to know is that the PCR studies have a very high negative predictive value, all right, of 93 to 98%. If the test is negative and the patient was appropriately screened, meaning their pretest probability is moderate to high, and they have a negative test, that is very, very, very likely to be a true negative test, and you're done. If they have a positive PCR, it really doesn't mean, it really means one of two things. Either they have C. difficile infection or they are a carrier, all right? And antigen and toxin helps. And so if you order a PCR, toxigenic PCR, reflexively our labs are usually ordering antigen and toxin with it to kind of help us with that. And if they haven't done it, make sure you order that. So what if you have a positive PCR patient, positive antigen patient, and a negative toxin patient? What do you do with this? And I've had this come up a few times in the hospital and several times in practice. Is this a carrier patient? And I always inquire, have they had C. difficile, or are they an inflammatory bowel patient? Because quite a few of our inflammatory bowel patients have had C. diff, some haven't, but they end up with this kind of scenario quite frequently. And what do you do to treat those patients? Well, it's I think, individualized. Some of these patients I've treated and some I haven't. I had one recently that's enrolled in drug study that came up with this, and the study monitor and the drug company scientific team, I mean, we had a big, long discussion about, do we treat this patient or not? The patient was clinically the same. He was having 6 to 8 bowel movements a day but hadn't changed a single bit, and we decided that it was just a carrier state, and we did not treat his C. diff, and we dosed his study drug. If a patient is not improving, all right, and they have a positive PCR antigen, negative toxin, and they're not improving, these are patients, I think, that should be scoped if they're in the hospital and they're sick, all right, because some of these patients, especially the ones that haven't been treated, some of these patients have pseudomembranes, and they they do not make toxin, but they have C. difficile infection. And I've seen that before where it's like, gosh, you've had multiple negative C. difficile studies, you'd put a scope in, you see pseudomembranes everywhere, and then you need to appropriately get them on therapy. So the diagnostic algorithm for C. difficile infection, you can either do a nucleic acid test, a PCR test, or antigen. If positive, you get toxin A and B, and CDI is likely. If the nucleic acid, if the PCR test is negative, CDI is unlikely to be present. And then working through an algorithm on the antigen toxin side, if they're both negative, it's unlikely to be C. difficile infection. So some words about, you can't talk about C. diff without talking about fecal microbiome transplant. When I gave my talk a while back, these are our nurses in the GI lab helping prepare donor stool for fecal transplant. And we reminisce. They honestly hated this, and they thought it was the worst person every time I ordered it. But they helped prepare our donor transplants. These days, we haven't done a donor transplant like this for probably about 5 years. There's a commercial company out there called Microbiome that does all the testing. And this is an advertisement on the Massachusetts public subway, whatever it is, about donating your stool and getting paid for it from the company. And so we buy donor stool, and this is the way that it's done now at the hospitals that we work for. And each of these specimens cost about, they cost about $500 per specimen until about a month ago, and the price went up to $1,000. Actually, no, it went to $2,000. So it went from $500 to $2,000 per specimen, and we've had significant problems with insurance companies agreeing to pay for that. So a meta-analysis of 18 studies, 611 patients. The primary cure rate is 91% overall. Better if it's done through colonoscopy and you're a younger patient. Not quite as good results if it's done through an NJ tube or you're an older patient. We never do it through NJ tube. Just the thought of someone having an ileus and vomiting a donor stool transplant just makes me cringe, and so we've never done that. It's not as effective. Recurrence rates are quite low. They are more common in recurrences in patients that are older than age 65, at about 10% overall, and less common if you're younger than 65. So safety appears to be very safe. There are some GI symptoms I've seen, bloating. I had a patient that had sort of an IBS diarrhea problem before fecal transplant and then had a problem with constipation after transplant. I remember saying, well, who did we get this stool from? And he's like, well, my girlfriend donated. I said, well, you've got to blame her for that, right? You're constipated now because of her biome, you know. And he thought that was kind of funny. But we do see some of these GI symptoms. They're they're really short-lived, and patients overall very happy. We haven't had bacteremia. I have not seen it. Diverticulitis norovirus, exacerbation of CMV, or other infectious complications related to fecal transplant. So moving on, fecal microbiome testing. Has anyone here had a patient ask about testing their microbiome? I see a hand go up. And so I wanted to present a clinical case. 36-year-old postgrad student, longstanding GI history, diarrhea, predominant irritable bowel. He's had SIBO and has been treated for bacterial overgrowth with a couple different antibiotics, and he takes probiotics. He read about microbiome testing and wants to have it ordered. So what do we know about the gut microbiome is that there are several hundred genera of bacteria. The most common are the Bacteroides and the Firmicutes. The bacterial population density is about 10 to the second, 10 to the third in the ileum jejunum, about 10 to the seventh, 10 to the eighth in the distal ileum, and in the ascending colon, the bacterial density increases to 10 to the 11th per gram of stool. All right, so we're talking a huge jump up in the amount of bacteria. and that doing a colon lavage significantly changes the cellular makeup of our body temporarily. I read about this. I was preparing for that talk and gained a greater appreciation of it, that there is roughly a third more cells in our gut microbiome than there are of all of the human cells combined. And if you give a colon lavage with gabalite or whatever, you're wiping out a good majority of it, at least temporarily, and you're changing that cellular makeup considerably. So the gut microbiome, integral to human physiology, wide-ranging effects on immune system, development function, energy metabolism. Researchers are looking at therapeutic targeting with the goal to improve health, understand and prevent medical conditions, and they have advancements in DNA sequencing technologies, these 16S ribosomal gene targeting and metagenomics, and all of this has led into a lot of research. And kind of a nice slide that tells us some of the potential effects of the microbiome on the gut-brain axis, the intestinal barrier function, motility and sensation in your GI tract, and immune activation. So this is a list that really gets to sort of the heart of who is doing microbiome testing out there. And I am personally most familiar with a company called Genova at the bottom, and we'll get to that in a little bit. But they're probably the two most well-known companies is a company called Ubiome. That is a commercial company that started in California, the Silicon Valley area, that is using machine learning, artificial intelligence, and statistical techniques and patented 16S ribosomal sequencing techniques to sequence gut microbiome. They charge patients for this, and they've been involved in some interesting and somewhat sketchy practices recently I'll get into. American Gut was established by Rob Knight, his lab at UCSD, and is what's unique about them is they're researchers, and they have created the world's largest crowd-funded citizen science project of microbiome testing. And we'll talk about that in just a second. So, Ubiome made the news last month, raided by the FBI, and allegedly what they're doing is they're billing patients insurance, and patients don't know, and billing the insurance company over and over again for testing that appear to be somewhat fraudulent. And so their chief science officer and their CEO have been put on administrative leave, and the company's in all kinds of trouble right now. So a little bit about American Gut, Human Food Project, is, and I don't remember, when I was president a few years ago of the Ogden Surgical Society, we had a keynote speaker, Rob Dunn, who was heavily interested, had written a book about the human microbiome, and was very, very much interested. And he is a part of the Human Food Project, American Gut Project. He's one of their researchers and on their board. But basically what you do is you donate. You collect a sample, you mail it off, it costs $99. You take it from gut, mouth, or skin. You can even take it from your dog. You mail the samples back. They ask a bunch of questions about diet and other questions. They do the sequencing, and then they give you a report like this. This is your American Gut sample. It will give you kind of an idea of where you stand in relation to patients with different ages and populations. This person right here sits about here, in comparison to the Western age group, and also how you compare against the other American gut population. They take samples from all over the world, outside of Europe, and I think Australia are the biggest outside groups that are participating in American Gut. So this is a sample very comparable to a sample I received from a patient that came to me that wanted to have their microbiome tested. And kind of hard to read these numbers, but this was billed to their insurance. And this test on the left, whoops, let me go back, gave sort of a breakdown of what their microbiome sample looked like, relative abundance of the different bacteria. In the middle, they also tested for things like pancreatic fecal elastase and some inflammatory markers, calprotectin, and free fatty acids and that. And then they gave this sort of GI effects comprehensive profile at a glance. This person's infectious profile was fine. They had some fecal secretory IgA. There was no evidence of pancreatic insufficiency. There appears to be an imbalance in beneficial bacteria, and then they get this sort of graphical images of your bacterial microbiome. So my problem with this was when they brought it, he's like, okay, here it is. You know, I've done this really cool thing. Now help me figure out my gut. And I was like, oh, geez, you know, I'm not sure. This is helping me figure you out. And so I haven't seen one of these tests ordered for a few years. So the AGA put out a paper, very, very recent paper about this and about how they felt about microbiome testing, that there are significant limitations, that the sample really is impacted by how it was collected and stored. The microbiome degrades if you sit it there. I mean, if you leave it out in the sun in your garage because it's like, I can't refrigerate it, you know, and it's... So samples degrade if, depending on how they're collected, how they're stored. Data about the virus and the protozoa and the fungal data is very, very limited in the microbiome at this time. Where you sample is important, and it's different depending on where you sample. Single specimens are snapshots. They're incomplete and limited. Often the reports are good versus bad. They're overly simplistic. A lot of these companies are not designed for accurate pathogen identification, so they'll tell a patient, oh yeah, this is bad because it has X, Y, and Z pathogens, but they're not really designed to do that, and they're not accurate. There is no single healthy microbiome profile, and that's going to be several years, if not decades off, so we really understand how everything works together. So the AGA basically says that microbiome testing is currently not suited for diagnosis of infectious disease or validated for treatment of any disease. And so if a patient comes to your office, I think America Gut, that kind of citizen science project is interesting. I think if they have the money to participate, that's a worthy thing to do. But as far as using that to make a clinical decision, it's just not possible. So moving on to colon cancer screening, I want to talk about and maybe touch home on something I've seen lately. So 50-year-old patient is refusing a colonoscopy. What are your options? And notice I only put 3 things up here. I could have put 4, and I didn't, but I put up 3. Hemocold on the left, a fecal immunochemical test, or the FIT test in the middle, and then stool DNA testing or Cologuard on the right. So we're familiar that colorectal cancer is the leading cause of death in the United States, 4th most common cancer. Overall lifetime risk is about 5%, and incidence and mortality rates have been decreasing over the last 30 years. But interestingly, and for reasons that we're not quite sure, and that's possibly related to obesity, is that we're seeing increasing incidence rates among patients who are 40 to 49 years old. And so recently you've heard that the screening guidelines have changed to start at age 45 in patients, average risk patients. And we advocate that. The problem is getting that covered by insurance. All right? How many people know someone who had colon cancer between the age of 40 and 49? So my cousin died of, I diagnosed his colon cancer about 6 years ago. He's 47 years old on a Friday, average risk, had symptoms for about a month, and died within 9 months of stage 4 colon cancer. So it's out there, and it's happening to people that we know. So guideline recommendations for screening, any of these, except for Septin 9, is a screening option. A FIT test every year a colonoscopy every 10 years, a stool DNA study every 3 years. Notice I didn't really talk about sigmoidoscopy. I don't recommend just sigmoidoscopy because we have colonoscopy. And I really, with CT colonography, has some problems with it. Mainly, I believe, is radiation exposure and difficulty seeing small polyps. And expense. It's expensive. So I won't get into this much, but fecal occult blood testing reduces colorectal cancer mortality. Multiple studies over the years have shown that this test reduces mortality, a yearly fecal occult blood. There's reasons why this has fallen out of favor. It takes 3 samples. There's a special diet, but it is an option. The FIT study we've all heard about, and this is, I think, where a lot of our screening happens, is a labeled antibody that detects the globin protein of human hemoglobin, and has several advantages over a fecal occult blood test, a hemosense type of test. There's no restrictions on diet or medications. There's improved adherence, and the results are more specific to colorectal origin because globulin protein is degraded by pancreatic enzymes. So there's a lower false positivity rate from, say, a source that's above the level of the small bowel. So FIT performance for colorectal cancer screening has a sensitivity of about 79%, specificity of 94%, meaning that the false positive rate is quite low for this. There are no randomized as of yet, but I think this will change in the future. These studies are hard to do. No randomized or observational cohort studies showing reduction in colorectal cancer incidence or mortality. This is a really valid option, I think, for patients is FIT testing for screening if they really don't want to have a colonoscopy. So I want to talk about multi-target stool DNA testing, or Cologuard. Measures mutated DNA with the idea that neoplastic cells continuously shed their DNA into stool, and those cells have point mutations that can be identified by testing. So Cologuard checks for methylated BMP3, NDRG4, a mutant KRAS, beta-actin. It also has a FIT. This study, published in the New England Journal of Medicine in 2014, led to the FDA approval of Cologuard for screening for colorectal cancer average risk patients. And they enrolled just about almost 10,000 patients, and the comparison arm was a FIT study. And the results, the fecal DNA testing had a sensitivity of 92%, specificity of 86%, compared to FIT sensitivity of 74% and a higher sensitivity of 95%. Well, some concerns with this type of testing is it's expensive. Relative to FIT, FIT's about $25. Cologuard is about $500, and so it's more expensive. The screening interval is every 3 years. If you look at cost-effectiveness studies that have been published, and there's some that are published in the last year, it just doesn't hold up as well as FIT because it's more expensive. Patient's acceptance is a problem. FIT, you just grab the thing and just kind of dab it in the stool, and you put it back in the thing, you mail it off or bring it to your doctor's office. Stool DNA, you have to collect a whole bucket of stool. What I don't like is, and I think Robert is here, and he scoped some of these patients with positive Cologuards, is that the minute that comes to you, you're like, okay, I better find a polyp. Or I'm going to have to explain to a patient why they had a positive FIT. And I've had colonoscopies where I've done them, finished the kind of back and forth 2 or 3 times, then went back in again and came back a couple more times looking and didn't find anything. So there is a false positive rate with Cologuard of about 10%. And there's no randomized or observational cohort study showing reduction in colorectal cancer incidence and mortality. That's not surprising because those studies take a long time to do. And I think that given time, and I know these studies are being run currently, to kind of show that. So how do I manage a false positive Cologuard? I think I've had probably 4 I've had 4 Cologuards that I've done the last 2 years, and I think I found polyps in 3 of them, and one of them I didn't. Well, there's a couple of papers that have come out recently, and some posters that have been presented in the last year that suggest it's a bit conflicting, the data. The studies suggest overall that the risk of cancer in a false positive Cologuard test is very, very low. Very low. One group, basically, what they do is that they repeat the Cologuard at 1 year, and if the Cologuard is positive, they undergo colonoscopy. And in that particular study, a very small number of those patients had missed polyps. So the other study I read, basically, they did not repeat it. They followed them out and looked at mortality over a 5-year period, and mortality was very, very small, unrelated to colon cancer. And so I'm a bit conflicted. I think if a patient has a positive Cologuard and a negative colonoscopy, I would probably repeat their Cologuard at 1 year, at the 1 to 2 year interval. And if it's positive, repeat the colonoscopy. So I wanted to talk about hydrogen breath testing, move on and talk about that, and how I look at this in GI. I know that some of you have probably heard and taken care of patients that, yeah, my GI doctor has been treating SIBO and he did this breath test. I want to talk about that with a case. 28-year-old woman complains of longstanding gas, bloating, fecal urgency, diarrhea, worse after eating meals. She's had negative blood tests for celiac and has had a negative endoscopy and colonoscopy previously. And this kind of mirrors a lot of the kind of cases we see come to practice. What is the next step? So how does hydrogen breath testing work? Well, it's based upon the fact that there is no source of hydrogen gas in humans other than bacterial metabolism of carbohydrates. So you swallow a substrate, lactose, fructose, glucose, or lactulose. We don't do 14C xylose testing. But you swallow this substrate. It passes into small bowel. Intraluminal bacteria metabolize the substrate into carbon dioxide and hydrogen, which diffuses across the epithelium into blood and is exhaled and can be measured. Some of that substrate passes into colon, it's fermented by colonic bacteria, and gives patients diarrhea. So this we kind of talked about before, concentration of bacteria in different parts of the digestive tract. I won't get into this much, but know that obviously colon is the highest place, but there are bacteria in stomach, jejunum, and ileum. So how do we perform our hydrogen breath test, lactulose breath test? No antibiotics for 4 weeks. We stop promotility agents and laxatives for 1 week prior to the study. We ask our patients to be on a low-carbohydrate diet the day prior to testing. There's an overnight fast. We ask them not to smoke the day of the breath test and limit physical activity the day of the breath test, or the morning before they do the breath test and while they're doing their test. We give a dose of lactulose of 10 grams. We do breath testing every 2 hours, and these are the doses of the other carbohydrates that we give. Trying to look at my own thing here. Patient swallows it in a cup of water. Glucose is fermented. It's into hydrogen methane. Those are the gases that we measure. We use a machine that looks very similar to this, and we measure hydrogen and methane levels. So one of the things that's interesting is that how did we come to these carbohydrate levels? Well, when I was in fellowship at the University of Iowa, they did a lot of testing in fructose, and it's interesting. They signed up. Who's the easiest group of people to sign up at an academic medical center? The medical students and the residents and the fellows. And so they asked me to do one of these tests, and I reluctantly said yes. It wasn't a clinical trial, so I didn't sign a consent form, or there was no IRB, but I think they were trying to validate their instrument, because they came to me and said, yeah, we need you to do this, and I know you're in clinic, and you really haven't done a diet, but it doesn't matter. We're just trying to validate something. And so I took fructose, and I really believe they actually gave me a 50-gram dose of fructose. Oh, sorry, let me go back. So does anyone know how much fructose is in a can of soda pop? I mean, it's high fructose corn syrup. Well, it's about 30 grams, I believe. All right. So they gave me this 50-gram dose of fructose, and I don't know, within about an hour, I'm like, oh my gosh, my stomach feels like I feel like I've just like drank magnesium citrate or something. And so I'm in and running in the bathroom, out of the bathroom, in between clinic patients, and they're kind of laughing. They're like, you should never really do anything like this with Satish. Satish Rao was the researcher, and so come to find out, I found out through that and another test I had run that I have fructose intolerance. So they did studies looking at these carbohydrate loads and found that they took a look at about 15 patients that were healthy, no IBS diagnosis. They gave them gradated doses of fructose and looked at symptoms and malabsorption, and found that the majority of patients at 50 grams of fructose or higher have the potential to malabsorb and develop symptoms from it. And so that's why they chose the level of 25 as a cutoff. 50, everybody gets sick, and 25, it was lower. So an interesting kind of side note. So what are indications for hydrogen breath testing? Diagnosis of small intestinal bacterial overgrowth, slow transit constipation, because these patients make excessive methane. Some patients with slow transit constipation are methane producers, all right, from their bacteria. For other indications, for diagnosis of lactose and fructose malabsorption and unexplained symptoms, gas, bloating, diarrhea, and in some patients, constipation, as this group of patients is about 3 times more likely to have an abnormal breath test. So this is what we kind of look at. I wish all of our patients had graphs like this, but we just look at raw numbers. On the left is what a lactose and fructose breath test would look like. A patient is given at time 0 lactose, fructose to drink. We measure 30-minute hydrogen and methane levels, and you see here that this level increases quite a bit, greater than 20 from baseline, or a methane greater than or equal to 10 parts per million from baseline is a positive test. On the right is a positive SIBO breath test, where any rising greater than 20 or in hydrogen and 10 in methane from baseline is indicative of a positive test. Now, this test has a bit of controversy, because you might say, well, how do you know if that rise in hydrogen isn't reflective of arrival of lactulose to the colon? And that's one of the limitations of the study. If you have a patient with rapid GI transit, they might have a very early peak in their hydrogen and have a false positive test. And so we recognize that that's one of the limitations of the study. So this is a summary of SIBO-related data in IBS over many years. And disappointingly, depending on how this is done, where it's done, the sensitivities and specificities results of breath testing are all over the place. And that's really one of the knocks on the study is, well, I mean, it's not terribly accurate. You can have false positives and negatives. We've been, in my office, running breath testing for bacterial overgrowth for 15 years. And we've been using predominantly really the same machine. We've had to replace it a couple times. And our staff are comfortable with how to use it and how to interpret the tests. So what do we do in our practice? If a patient has gas, bloating, and diarrhea, and we suspect SIBO, bacterial overgrowth, or IBS diarrhea is suspected, we have a low threshold to do a lactulose breath test. It's not very expensive. In fact, we barely make enough money to pay for the supplies to do the test. I think we're reimbursed about $50 or $60. It's not very expensive. And if you have a positive patient, you give lactulose, they have a positive test, they develop symptoms from lactulose, and you treat them with rifaximin, and they have a response, that is a win for one of these patients that is really, they're very difficult to treat and control. These are patients that are frustrated, they don't have a diagnosis, no one listens to me, all the things you sort of hear. And so we have a low threshold to treat these patients. The other place where we really like to treat these patients is if a patient comes in and says, well, you know what, gosh, my diarrhea is so much worse if I drink soda pop, if I eat fruit, if I get it after I eat pancakes in the morning. They don't have celiac. I put all this syrup on there, and I have to run to the bathroom. I drink a big glass of orange juice. Fructose intolerance is when that's a positive test and we put someone on a diet, that is a very satisfying result for a patient. Very satisfying. They're like, oh my gosh, no one told me that fructose was screwing me up like this. I have had patients come in literally where they come in with the worst diarrhea ever. They've had a bunch of tests done, and you sit down with them, and you're like, well, how much soda pop you drinking? Well, I don't know, 64 ounces a day, maybe 100 ounces a day, and then, maybe a couple cans of Mountain Dew. It's always Mountain Dew. And then they relate stories like, yeah, gosh, on the way home, I had to pull over by Lagoon and go to the bathroom on the side of the road because I had diarrhea so bad. And you're like, gosh, and it's like, you got to stop. I can't do this. I can't do this. And I said, okay, well, then you can continue to mess yourself all over the place all the time. And it's so frustrating. And you sit there, and they're like, well, okay, maybe I can try to get off of Mountain Dew. Mountain Dew and Dr. Pepper are the worst, for me at least. I don't have people say, gosh, I can't give over my Coke and my Pepsi. It's something about Mountain Dew and Dr. Pepper. Anyway, so there's a lot of fructose in soda pop, and you need to look for that. So what do we do? If a patient is positive, they have a positive breath test, we treat with rifaximin or neomycin or metronidazole. If you try to prescribe Xifaxan, rifaximin to a patient for SIBO, it will be denied 8 times out of 10 by insurance. So, to get around that, we say, well, does your diarrhea cause abdominal pain, cramping in the lower abdomen, improved after going to the bathroom? Yes. You have IBS diarrhea with your SIBO, and IBS diarrhea is an indication for treatment with rifaximin, and it's covered by almost every insurance plan. All right? It is a prior auth, and sometimes you have to step through an antibiotic, but it is covered. If the lactulose breath test is negative, then we treat IBS diarrhea with eluxadoline by Bersey. If they have a gallbladder or a lecitron or amitriptyline plus an antidiarrheal and or cholestyramine. So a list of a couple different options. Has anyone had an opportunity to use Vyberzi in clinical practice? Yeah. And it works great for patients. You just have to make sure that they have a gallbladder. If they don't, you might give them pancreatitis, and then they'll be really mad at you. So if diarrhea, urgency, bloating is aggravated by exposure to fructose or lactose, we consider fructose or lactose breath testing. I don't do lactose very often. If a patient comes in and says, I think I have lactose intolerance, and you hear their story, it's like, you do. Go home. If you're not quite sure, I want you to go home. I want you to buy a pint of milk, chocolate milk if you want, and I want you to drink it. And if your symptoms come back, you have lactose intolerance. And they're usually pretty good with that. So we rarely do lactose. The only time we do lactose intolerance testing is in kids, adolescents. So moving to the last part of my talk is liver assessment of non-alcoholic fatty liver disease. So with a case, this is a 52-year-old man with hypertension, prediabetes, obesity, mild elevation in ALT, AST, total bilirubin, alk phos normal, ultrasound with fatty liver, negative acute hepatitis serologies. What additional workup? What do you do for this guy, right? And this is what, like almost every patient that we see, right? Going back to that, when is referral appropriate and when do you do a liver biopsy? So NAFLD is a huge problem. Affects 25% of the worldwide population. And really the real issue is NASH, non-alcoholic steatohepatitis. When you have NASH, you've progressed through to fibrosis, can progress faster. NASH affects about 1.5 to 5.5% of the general population. Is associated with obesity, type 2 diabetes, hyperlipidemia, metabolic syndrome. It is the most common cause of death, or the most common cause of death in patients with NASH, NAFLD, is cardiovascular, but there are liver-related comorbidities that are increasing, end-stage liver disease, hepatocellular carcinoma, and liver transplant. And NAFLD-NASH is expected to become the leading indication for liver transplant in the next 10 years. Important to know that the majority of fatty liver patients do not progress. So it's important to find the ones that will and obviously intervene on those patients. So this is a schematic of kind of the burden of disease, healthy liver on the left and cirrhotic liver on the right with hepatocellular carcinoma, liver failure and death. And if you look at that number, 86 to 110 million Americans in the U.S. have fatty liver disease. And 10 to 15 million have NASH, which is inflammation with fatty liver. And somewhere around 6 to 10 million may be affected with high-risk NASH. They've got these other risk factors. And those are the patients that are most likely to progress to cirrhosis. So this is a nice sort of look at histologically what happens in the liver as you progress through normal liver tissue to NASH and cirrhosis. And kind of a slide about the burden of disease that we just talked about. The second leading cause of liver transplant in 2008 was NASH, and predicted to be the #1 cause next year. And interestingly, in 2000, no liver transplants were performed for NASH. So what can we do? Well, there's invasive methods of working through and figuring out if someone has NASH and fibrosis. Obviously, the invasive method is a liver biopsy. The non-invasive methods are serum biomarkers or scoring indices. And the other non-invasive marker is a test called FibroScan. And if you look at this list of potential markers, there's something called the fatty liver index, the hepatosteatosis index, the steato test, and a bunch of others. Some of these indices require that you plug in the age and the sex. They evaluate the BMI and diabetes presence or not present, and then you throw in some of these other levels. I want to focus on 2 scoring indices that I think can be used in private practice. This is an article that was published about 2 weeks ago in our journal about the workup and non-invasive workup of non-alcohol fatty liver disease. So they made use in this, and they came up with a diagnostic algorithm of something called the NAFLD fibrosis score, the NFS. If you go on to mdcalc.com, or you really type in the NAFLD fibrosis score into Google, there are multiple websites that can produce this calculator to plug in variables that give you that help you determine what a patient's risk is of NASH and fibrosis. So the NAFLD score looks at age, BMI, AST, ALT, platelet count, and albumin. Everything that you have at your disposal in clinic you can plug into this scoring index. And what I like about it, and why they advocate using this scoring index, not so much because it's accurate, I mean, it does pretty good, but because it's validated with a negative predictive value of greater than 90%, meaning that if you get back a negative NAFLD fibrosis score or a low-risk score, the likelihood of having advanced fibrosis is very, very unlikely. And that's kind of where you want to be in practice, is to be able to say to your patient, you know what, you're actually okay for now. We're going to focus on these measures of weight loss and diet modification for the time being. And then we'll come back in 6 months to a year and repeat your numbers. The other score is the FIB-4 score, which is a fibrosis index that looks at age, AST, platelet count, and ALT. And has been validated with, again, a very high negative predictive value, greater than 90% for patients with advanced fibrosis, but must be used cautiously in patients less than 35 in age and older than 65. So this is the diagnostic algorithm that was published 2 weeks ago. So you have a patient that you suspect has non-alcoholic fatty liver disease. You have an ultrasound with steatosis. You might or might not have abnormal liver tests. This patient might have obesity, type 2 diabetes, or metabolic syndrome. They do not drink significant alcohol. And I think it's important, and it's a good practice to make sure they don't have viral hepatitis. Recognize that this algorithm is proposed is really an expert opinion algorithm. It's not based upon validated, obviously validated research. But what I like about it is that you screen, first line it says up on the left, primary health care, you screen with a FIB-4 or a NAFLD fibrosis score. If they're low risk, you attempt lifestyle modification and exercise, and no further assessment, repeat evaluation at a year. All right, you can kind of do one of those things. I would repeat an evaluation at a year and make sure that they've stayed where they're at. That evaluation would be blood test and kind of plug them back into the calculator. If a patient comes out with an intermediate to high risk screening test, that would be appropriate to say, okay, we're going to send you to GI and we're going to try to rule out advanced fibrosis. In this algorithm, you go to FibroScan. Who's familiar with FibroScan here that's ordered a FibroScan before? Have a couple. So FibroScan it's an ultrasound probe, measures wave shear velocity through the liver. It's a very quick test, 5 to 10 minutes, and it's covered by most insurances. So you can get a FibroScan at McKay-Dee. The physician group, gastroenterology group at McKay-Dee, bought a FibroScan machine, and they are happy to start seeing your patients. And I'm told that they have agreed to keep the costs low on patients. Now, when they said that, I was like, okay, that's interesting. Let's see how that really works out. But the idea is to keep it cost appropriate so that patients can actually afford it. The other place you can get a FibroScan is at IMC and at the University of Utah. So in this algorithm, you go to FibroScan. If you have a liver stiffness measurement less than 8, you're low risk, and you do lifestyle modifications, vitamin E, pioglitazone, or enroll in a clinical trial if there's something available. If your liver stiffness index or measurement is greater than 8, you're intermediate to high risk, you consider liver biopsy. So a little bit about treatment. There is no medication FDA approved for treatment of NAFLD, NASH. Management strategies really focus on weight loss, goal of 3 to 5% initially and up to 7 to 10% to improve fibrosis. Insulin sensitizers have been studied, metformin, data is conflicting. Pioglitazone has been studied as well, helps liver histology, but there's adverse effects with pioglitazone. High-dose vitamin E, 800 international units daily has been studied. seems to help liver histology, lower liver function tests, but does not help fibrosis. And there was a study that came out after that was published that showed all-cause mortality was increased. There's a modest increase of risk of prostate cancer in patients that take high-dose vitamin E for long periods of time. And so the excitement for vitamin E is kind of fallen away as well. There's really good data that bariatric surgery helps patients that have NAFLD, NASH. And I think it's appropriate to talk to your patients about that. And then lastly, I think there's multiple options, I think, coming down for enrolling in a drug study for treatment of NAFLD and NASH. So in conclusion, just back to C. diff, the PCR study has a high negative predictive value. But if you have a positive study, you need to differentiate between carrier and infection. Fecal microbiome testing is not ready for routine clinical use. Hydrogen breath testing can be useful for diagnosis of SIBO and carbohydrate malabsorption, but testing limitations exist. The high sensitivity fecal occult blood tests, FIT, and stool DNA testing are alternatives. They're all viable alternatives for screening. All of them require a colonoscopy if they're positive. And it's important to realize that with the Cologuard DNA test that there's false positives that make it kind of difficult for us a little bit. And importantly, use these scores, the FIB-4 or the NAFLD score, in your patients that come to clinic with NASH or with NAFLD fatty liver. And if it comes out intermediate, high risk, order a fibroscan and send them to GI. We'd be happy to see them and continue to evaluate and treat those patients. And that's it. I appreciate the opportunity to speak to you today.
Hi, I have a question about SIBO. So if someone improves with the antibiotics and then their symptoms return later, like how frequently can you repeat those, or what's your protocol for that?
We have some of our patients that we have had on cycling therapy because they only ever felt good, really good on antibiotics. So we have a low threshold to repeat. Well, we don't repeat testing, but we have a low threshold to retreat with antibiotics. And like I said, some of those patients need antibiotics. Well, I've done before where I'll have a patient on antibiotics the first 5 days of every month, and I'll cycle those antibiotics between Flagyl and neomycin. And the other 25 days of the month, they feel completely normal. But the minute they stop their antibiotics, their symptoms come back. Unfortunately, there's resistance problems. I've had a patient or two actually get C. diff with that, and then they get frustrated by C. diff.
Hi, I think he was next.
Oh, yeah, okay.
I've read several papers that suggest that people who have had an appendectomy are more likely to get C. diff.
So yes, I have heard of that as well.
So, is there a teleologic reason for the appendix other than surgeons helping their kids through medical school?
Robert, why don't you step up? He's going to help me with this answer.
What I'm saying is, my thought is that the appendix is teleologically developed as a reservoir of the biome.
Yeah, and there's a lot of thinking and a lot of research to suggest that that's absolutely true, that the appendix does play a role. We see problems with appendectomy and risk of Crohn's. We see it in, obviously there's observational data to suggest that there's a higher risk of C. difficile infection. And it's interesting. I believe that it actually does play an important role that clearly we don't understand completely. And hopefully we'll understand that more as we understand what makes up our microbiome and site-specific biomes like the appendix. How does the proximal colon, the terminal ileum, the very most part of the terminal ileum play into that? Thanks. Go ahead.
So with the fatty liver disease, I have patients a lot that will show up in my office and we're doing their like routine labs, and I note that they have elevated AST and ALT, and then I ask them about it, and they're like, oh yeah, like a long, long time ago, they told me I had fatty liver disease, and I'm like, well, did you ever get followed up? And so my question is, how often do they need to have follow-up? You said 1 year if they're in that low-risk category, but what if they were in the higher risk and they did the FibroScan or they had a liver biopsy and it was negative? When do they need to follow up again?
You know, that's a good question. I think that they should. I think our liver patients should be assessed at least every 1 to 2 years. If they're high risk, they should be assessed at least yearly and maybe every 6 months for follow-up. Now, how do you assess? Do you repeat a FibroScan? Do you repeat a liver biopsy? I don't think we know that for sure, but I think that liver biopsies are hard to sell to patients, a repeat liver biopsy, if they've been previously biopsied and have NASH. I think a FibroScan is an excellent modality that you can get. And if someone's been a diagnosis-proven NASH patient without fibrosis or very minimal fibrosis, I would repeat the scan. If they have a positive FibroScan that's high risk for fibrosis, that's where I would say, okay, you know what, you need more intensive management. You can't disappear for 2 years or 3 years or whatever, and your BMI is too high, and your high blood pressure, and your diabetes, and all those things. We're going to send you back to GI and see if we can get you maybe followed up with them, but also maybe enrolled in a drug study.
Could you please comment on organic acids and actually look for butyrate and other metabolites of bacteria for looking for SIBO and other GI problems?
Yeah, I don't know if you noticed on that Geneva diagnostic stool study, they actually check for some of those things.
Yeah, I was curious what the specificity, et cetera, because I've heard of other doctors, I've talked to doctors and of patients, and they say, yeah, we routinely do organic acids, looking for butyrate and these sort of things, as opposed to doing some of the more aggressive things. So I was just curious about your feelings on that.
You know, I haven't used that in my practice, and I haven't seen a lot of study on that in SIBO. So I haven't personally used that kind of testing. So I'm not sure that I can answer that very well, but I know that Geneva labs and some of these labs can test for it. We just haven't used it.
Okay, thank you.
Chad, is there any research done on specific diets as far as fatty liver disease? A lot of our, at least on CT, when we see fatty liver, the patients are overweight and have, a body habitus. But occasionally, I've seen some particularly fatty livers in patients that are even thin. And I know there's genetic components and things like that, but for those patients, if they are already at a normal body weight, does low carb diet help those folks? Has that been looked into? Is that a silly thought? I've wondered that myself, and I know they've studied the Mediterranean diet. I know they've in fatty liver. Some of the issues that with diet is compliance. Patients actually agreeing to do it. I think diet does help. I think Mediterranean diet's, a good diet. I think a low-carb diet can be useful as well. But again, I'm not sure that there's a lot of data to support that.
Preferred probiotic that you recommend to patients, and for how long, typically?
Yeah, so we get this question quite a bit is, after treatment of SIBO, should I take a probiotic? And I tell them that the research in probiotics and SIBO there basically isn't a lot of research. Probiotics are not harmful to patients. I tell them that the only thing that really harms is your wallet, that some of them can be quite expensive. If a patient of mine is going to use a probiotic, I like VSL number 3, if you're familiar with it. If you www.vsl3.com. It's a huge probiotic. It has, per dose, it's like 60 billion bacteria. And it's been pretty well studied in the setting of ulcerative proctitis and IBS, irritable bowel. And it has some pretty good data to support that it might be useful. As far as using it in patients after antibiotics for SIBO, I tell them that they're welcome to use it if they like, to in theory, reestablish or maybe provide some benefit to their microbiome that now has been altered by antibiotics. But the data is really iffy for that. The other place I tell patients with probiotics that there's recent data to support is using probiotics while you're taking antibiotics for an infection in a patient who's had recurrent CDI, recurrent C. difficile infection. That taking a probiotic while you're taking your antibiotic decreases the risk of recurrent C. difficile infection. But again, the problem with that is that you're telling someone to take a probiotic, and is it even close to or similar to the probiotic they use in the clinical trials that reported benefit? So I just remind patients that this may be beneficial, but again, I can't prescribe the same probiotic they use in that clinical trial. I'm just asking you to find one that you can buy at the store that's cost effective for you. And so that's one place where I think probiotics are also useful. But if I had to choose, VSL number 3, irritable bowel syndrome, and ulcerative proctitis. So I think for IBS diarrhea in patients, I'll tell them to use 8 to 12 weeks worth. Our patients that have ulcerative proctitis, we use it for maintenance, and they'll continue it indefinitely as long as it's not too expensive or causing them side effects. Yeah.
Hey, great lecture. First question should be quick and easy. For the SIBO, you listed, aside from Xifaxan, the metronidazole as one option. And then what was the other?
Neomycin.
Yeah. How do you feel like those compare to the Xifaxan?
Well, that's a good one. I think that neomycin is I think neomycin is a good antibiotic. I think it's helped a lot of our patients. Xifaxan, I think, is the best. I think if I had to choose, Xifaxan, neomycin, then Flagyl.
Okay.
Metronidazole is difficult for patients. They get nausea. And neomycin is inexpensive and very low risk.
Okay.
Xifaxan is too expensive for a lot of people.
Then my next question, I thought the algorithm about the NAFLD was interesting, and it had the risk factors off to the side for when you might consider going down that diagnostic algorithm. And one thing I wanted you to clarify for me was, because you said with NAFLD that you don't necessarily have elevated transaminases. And then on the risk factors for NAFLD, one of them was listed as steatosis, which I kind of like interpreted that almost to be like the same thing. So what is the difference between steatosis on imaging and NAFLD?
Well, steatosis is the term for fatty liver. So a lot of, when you get your ultrasound result back, it'll say fatty liver infiltration. So I consider that the same thing.
Same thing. Okay.
Yeah. Well, thank you.
I have a super quick
Everyone survived. Oh, one more question.
Super quick. So, do we need to let our kids play in the dirt and eat the dirt and all that to actually establish their microbiome? I mean, are we just keeping things too clean, and that's why we're having a hard time and having to do fecal transplants? And
it's a good question. There's a book out there by Rob Knight who established the American Gut Project, and it is, should our kids be eating dirt? It was out there, and I was just about ready to buy it, but the line was too long before the session. But I believe that the future will show that we live in a very sterile environment, and that's harmful for our microbiome. Should a kid eat dirt? I think they should play in the dirt.
I do too.
I think most of us played in the dirt when we were little. My kids don't play in the dirt very much anymore. And I think that's detrimental to their health. And that's probably why they get so many allergies and they have so many, other issues in life.
I agree. And that fermented foods, too, I think they talk quite a bit about eating some of that kind of stuff, too. But, yeah, I think so. And that was a great presentation. Thank you.
Uh-huh.